All right, so sickle cell disease. We'll finish sickle cell and we'll take another break. So sickle cell disease can develop sickle cell anemia, right? So it's a state where you have a low O2 state because we can't get the RBCs where they need to. They sickle, right? When they sickle, they change shape and they start clogging the organs and clogging the vessels, and therefore distally there is low oxygen, right? Low oxygen state. And these are called sickle cell crises. And anything can be a crisis. So they can have low flow to their brain and get a stroke. They can have low flow to the heart and have a heart attack, low flow to their lungs and have the lungs fail, right? They can have low flow to their kidneys, to their digits. That's called dactylitis, right? Their digits start to become necrosed because they have low flow there, right? Also low flow to the penis, and they get priapism. They have low flow to their bone marrow, low flow to their spleen. The spleen shuts down. They're functionally asplenic. And what's our spleen for again? It stores stuff. It stores B cells and T cells. It's like the headquarters, like the guards that are on duty, right? They're there waiting for something to come through. But if they don't have the blood supply, then the guards die, and then you can't fight off infections, right? So they are functionally asplenic usually. Okay, and what makes sickle cells sickle, what makes them change shape is low oxygen and cold and acidosis. So that little triad of things is really what you want to try to avoid. That is your priority intervention, to warm them up, to give them oxygen, right? So when it has a pneumonia and they have sickle cell disease, like, oh cool, they're just on 2 liters. No, they are actually super critical. They can easily sickle and get a stroke or heart attack, priapism, et cetera on you, okay? So acidosis usually happens because of low O2, but we want to try to correct that if possible. All right, so sickling is the problem here. All right, so sickle cell disease. All right, so it is the most common inherited disorder, right, worldwide, and it is often found in Mediterranean areas, African descent, and it's due to a genetic mutation. It's autosomal recessive. So if you can do your Punnett square from science, right, you find out that if mom and dad have it, right, then what's the percent chance your kids would get it? It's 25%, right? That's what they both have it, right? So they can be, then sometimes if they meet with someone that does not have it at all, then you just have carriers of the disease, 25% chance of carrying it, okay? Did I say 25%? 25%, sorry. Affected 1 in 4. All right, so then they have sickle cell disease, or sickle cell trait means you can pass it along. All right, so the sickle cell disease RBCs, the sickled RBCs become defective. They have a mutation in one of the hemoglobins, specifically hemoglobin A. They call it is the sickled hemoglobin. They call it hemoglobin S as well. So that hemoglobin doesn't function great when it's under stress. Right, so the O2 is low. All right, so when the O2 is low, then that's what prompts it to sickle, right? So basically when you have a low O2 state, right, remember your hemoglobin association curve, everybody, right? All right, so your O2 hemoglobin association curve, the hemoglobin will change shape and become less, doesn't like O2 as much, and O2 affinity is poor, and O2 will then leave the hemoglobin molecule and go to the tissues that need it, right? It deforms nicely, right? This is sickle cell disease. It just deforms and then it becomes sickled. It pulls everything with it, right? And becomes sickled. It pulls all little microtubules and everything and it sickles the whole cell when the O2 gets low. When the O2 is adequate, right, it's doing its normal function. But when the O2 just trickles down a little bit, right, and the stats drop a little bit and the PO2 drops a little bit, it's going to pull everything with it and become sickled, okay? So you have low O2 carrying capacity, all right? And low flexibility. It's not able to go through like normal RBCs. They can make their way through any tiny shape and deform as much as possible to get through. Whereas our sickle cell patients don't have cells that are that agile, and therefore they can clog and clot and cause a sickle cell crisis, right? So with a normal lifespan for an RBC is about 4 months. This is 3 weeks, all right, 20 days. 15 to 20 days is how long it takes for a sickle cell to survive, or how long it survives. And it's constantly being turned over, so they have a lot of hemolysis happening. So like we mentioned, it's not fragile, sorry, it's not flexible, but it's also super fragile. So it also breaks. If it gets stuck in somewhere, it's just going to pop open, and all of its contents are going to pop out, and its contents being LDH and heme. Haptoglobin stops it up, and we can get a little bit of jaundice as well. Okay, so these are all of our signs of hemolysis that are also associated with B12 and folate, but also carry over to sickle cell disease, right? So the problem is when we get a sickle cell crisis, right, and different organs can shut down, and we get they're in severe pain. We never deny pain meds or opiates to sickle cell patients because, oh, you're fine, you're just on your phone. They are in extreme pain. They've been working with this chronic pain for a long time, all right? But what we can do is give the pain meds, but also make sure we are fixing any kind of O2 deficit, right? So they have any increased O2 demand, we need to fix that. So they have a pneumonia, we should be, making sure the stats are good, making sure they're doing all their IS and all that other fun stuff, right? Pregnancy puts you at 22x risk of fetal demise. It's a huge O2 demand. Infection can be a death sentence for a patient with sickle cell disease. So it's not just like any other sepsis patient. They are high priority, right? If you're looking at prioritization. On exertion, these guys have exercise intolerance, obviously because of the low O2 state, but also they develop an acute sickle cell crisis or even profound pain if they overexert themselves. Okay, and then acidosis. So acidosis happens when you have low O2. All right, so that can happen with infection. So infection can cause hypoxia if it's pneumonia. Also, infection can cause widespread inflammatory response and shut down organs and increase lactic acidosis, right? So infection can cause acidosis. DKA and kidney disease will also make you acidotic, so that's something to avoid. And then dehydration. So overexerting yourself can cause dehydration, but just also being dehydrated will make your cells clog more than average. So we're going to make sure they're well hydrated. And then vasoconstriction. So if it had a problem getting through a vessel this size, imagine if it is much smaller. So we want to avoid cold. We want to make sure they're warm. Make sure they're not taking ETOH. ETOH is a direct vasoconstrictor. So that's not a good thing to recommend. And stress causes your SNS response to fire off, and your alpha-1 receptors will activate and you'll vasoconstrict. Infection will promote clotting and further clogging. So that's not, so you can see infection checks all those boxes. All right, so we have all kinds of issues that might cause dehydration, might cause low O2, might cause acidosis, and ultimately we get pain crises, which is manageable. They are in the hospital many times, at least 4 to 5 times a year usually, and they usually for pain, but it can be something much more serious, where they have what's called chest syndrome, where they have an infection causing them to have chest pain, or they have an actual heart attack, or they have a pulmonary embolism. All of these things are classified as an acute chest syndrome, and that's the most severe complication that can occur with sickle cell disease. So acute chest syndrome is outlined on the next slide, but also here. All right, so that is sickle cell overview. So what are the symptoms? Well, it's the same symptoms of anemia, but also it's going to be exacerbated when we have hypoxia, acidosis, or dehydration. They usually present with these pain crises, right? That's the most common, and it's located in the lower back, in the thighs, the skin is like all over pain, okay? And then our goal is to get their pain meds within 30 minutes or less, right? That's usually the goal when someone comes to sickle cell crisis. Because if we don't, they're going to get more stressed and they're going to have more vasoconstriction. And vasoconstriction is not good, right? And these sickle cell crises can also develop into deadly complications. Those that are highlighted here, these are all deadly, but those that are highlighted are actually extra deadly, extra spicy, and they need to be addressed immediately, right? So acute chest syndrome, that's where they're having a heart attack. That's where they're having a PE. That's where they're having a pneumonia. Right? That is a medical emergency for a sickle cell disease patient. All right? So pneumonia, they have sputum, they have on x-ray, they have infiltrates, right? That's a bad situation for a sickle cell patient. Usually sickle cell patients are like in their 20s and 30s, and they don't look that bad, but they have a pneumonia, they're at very, very high risk of deteriorating. All right, so they can have what's a vaso-occlusive occlusion, a vaso-occlusive process, right, where the organ is becoming infarcted because it can't get through, right? The blood can't get through to the organ because it has sickled. The cell is sickled inside, and then the organ starts dying. Okay. Other medical emergencies in the yellow there, we got strokes. We got stroke-like symptoms. What's a stroke-like symptom? That's B fast, right? They got balance, eyes, face, arm, speech. Those things are focally not working acute. Like you recognize they were fine at 7 o'clock, and at 9 o'clock they have a facial droop, or they have face issues or speech issues, right? And then priapism. What's priapism again? Mm-hmm. Used to be more than 4 hours. These guys got together and they said, no, 3 hours, please. So erection lasting more than 3 hours is priapism. And then we have pulmonary infection. Again, that can then lead to hypoxia. Hypoxia can lead to more sickling and then an MI for that matter. We can have chronic dysfunction. Chronic dysfunction being that their spleen can shut down, their kidneys can shut down, their femoral head, their hip, right? That can just become necrotic. As common with, because it gets a little blood supply already, but then with sickling, it's going to lose a lot more blood supply. All right, and then spleen is, if it's not already dead from splenic infarction, you're functionally asplenic. It doesn't work great. It's not able to fight off infections that well. So these guys usually have to be vaccinated. They have to be vaccinated against things that the spleen would normally attack, right? And that would include different pneumonias, different pneumonia bugs, H. influenzae and strep pneumonia, meningitis. They have to take their meningitis vaccine in meningitis, right? H. influenzae also causes meningitis. And then we have osteo. It can be caused by salmonella. There's no salmonella vaccine, unfortunately, right? But we'll point out these on the next slide. We're talking about vaccinations. And then hemolytic crises. They can cause widespread hemolysis. If you have widespread sickling, your spleen and everything's going to go overboard, and they're going to cause widespread hemolysis, right? It is normocytic. There's not big or small. You're making RBCs just fine. There's no problem making RBCs. It's just they are dysfunctional RBCs. Whenever O2 gets low, they start sickling. Whenever you get acidotic, they sickle. Whenever you get dehydrated, you're also vasoconstricted. But those things are going to cause a sickle event, right? And there's such thing as an aplastic crisis. So if your femoral head of your bone got occluded, well, how about the whole bone itself? That's the bone marrow, right? So the bone marrow gets occluded, and now you're not producing RBCs. You're not producing, which is not great, because now you're going to get hypoxic, and then your platelets can be low, and your white count can be low. So they're a high risk for infection if they weren't already, right? So highlighted in red here are medical emergencies, but everything can pretty much become occluded and occlusive. All right, so what are some diagnostic tests you can do? Well, CBC, AHH might be low. You're going to have normal stuff, right? Everything looks the same, except what happens? When you're hypoxic, when you're acidotic. During crisis is the right answer, but hypoxic, acidotic, or dehydrated. Usually those are three big things, overarching things. You just think of anything that could cause that, right? They are on a hot summer day in Antelope Valley, they are high risk for sickle cell disease, right? Or sickle cell crises. And then reticulocytes. So they still make reticulocytes, right? So you're going to have a lot more reticulocytes circulating around. And then hemolysis will happen. As we mentioned, the bilirubin will go up, the haptoglobin will go down, the LDH will go up. The spleen will get big as it starts to chew all these extra things. And then complications. We want to make sure we're looking to see X-ray. If they have what? They have a pneumonia, right? CT head and abdomen and chest, also to see if they have an infectious process there. X-ray to see if they have a necrosis of the shoulder, necrosis with the hip. These things can cause, we can look to see if there's splenic crises there, or sorry, sickle cell crises there. Okay, what else? So they don't heal good because their bone marrow can be dysfunctional, right? Can not work. All right, what else? We talked about these different tests already. The different haptoglobin, the LDH, these will be, which one will be elevated? LDH or haptoglobin? LDH, that's inside every RBC and every cell for that matter. But the haptoglobin is what scoops up all the extra hemoglobin out there. We can do tests to see what kind of variant they have. Hemoglobin S obviously being the actual sickle cell disease compared to just being a sickle cell trait. Remember, the reticulocytes are backup. Okay. And then what else? So we have the normal process, just to re-illustrate what happens normally when you hemolyze, right? Because how long do these guys stay around, these cells? Only about 20 days, right, compared to a normal RBC of 120 days. So you're constantly turning over RBCs. All right, there's an example of dactylitis, right, where the digits become occluded and necrosed. Okay, so we need to restore blood volume or fluid volume, and we need to restore fix acidosis. We need to do everything that we can to reverse that. All right, so what's the treatment for sickle cell disease? The really only true treatment is a stem cell transplant, a hematopoietic stem cell transplant. It used to be where you'd take a big sample for someone else and then you inject that into someone else after you've destroyed their bone marrow. But here you can do autologous, so you can do someone else's blood and someone else's stem cells. It gets treated, right? And then you get blasted with chemotherapy, and basically your bone marrow is starting from zero, like turning it off and on again. And you're obviously at severe risk for infection at that point. But once you are recovered, or for 3 to 4 weeks or so, then we can start injecting via IV. We can do someone else's stem cells or your own stem cells. What's that? It's curative, but it's 87% effective, right? It's very, very rare to find it. There's many HLA markers you have to meet, and it has a very high mortality in of itself. It's like a 1 in 4 chance you will die when you get this therapy, right? But I don't think I pointed out, I think it was on the previous slide, most sickle cell patients don't make it past their 40s, right? It's usually they die in their 40s because of all these different complications, okay? Usually pediatric patients have a lot better outcomes when they have these stem cell transplants. Okay, so crisis treatments. So obviously we got to fix hypoxia, fix acidosis, fix dehydration. So that's what we're going to do. O2 sats low, give O2, right? Get a chest X-ray. ABG will tell you what? It'll tell you what the SpO2 is, but it'll also tell you what the PO2 is, right? It'll tell you if they are hypoxic or hypoxemic. To see if they have acute chest syndrome, give fluids. That'll fix acidosis and dehydration. Normal saline actually promotes acidosis. That's not the best thing to do. LR would be better. And then antibiotics, they probably have a community-acquired pneumonia, so we're going to punch in our antibiotics there, right? And then analgesia. Our goal is within 30 minutes to get them some kind of pain coverage, right? Because the pain will put them in more stress, and more stress is more SNS, and more SNS is more vasoconstriction, more sickle cell crises. All right, so we mentioned those things that were highlighted in red and yellow. Those things are red flags that need to be treated immediately, right? So you can't just do, let's give them fluids and oxygen. You have to set up a massive, not transfusion, a massive exchange transfusion, where you take all the blood out of them and replace with brand new blood, someone else's blood, right? So it's about 6 to 8 units of blood. You take it all out and put it back in, right? So that's going to do an exchange of their blood for someone else's blood, right? That's when they have those symptoms there. Otherwise, how do you keep them at bay? Hydroxyurea is it's a chemotherapy drug, really, but it's also used for sickle cell patients to produce a different hemoglobin. We have different hemoglobins out there. They have hemoglobin S. This one produces fetal hemoglobin, or hemoglobin F. And fetal hemoglobin does not sickle. So that's great. Now we have functional fetal hemoglobin, right? So it makes them survive longer, right? When they have more than 4 crises per year, that's usually when we switch them over to hydroxyurea. Because hydroxyurea itself is a chemo drug. It's going to have a lot of bad side effects, such as shutting your bone marrow down, which puts you at risk for infection, which puts you at risk for all the problems you mentioned above. Okay. The other thing to fix them is to give blood, someone else's blood, just like a 1 unit, 2 unit transfusion, or not a whole exchange, but just 1 or 2 units to help dilute out their sickled cells, right? So they have a mix of cells, right? And they get a lot of blood transfusions, about 100 per year is usually pretty standard for sickle cell patients, right? So that being said, they can have an iron overload because iron's in that blood, and you can have extra iron. You get iron toxic, and they get gold in appearance. They get an eternal tan, right? And if that's the case, it can then deposit in the liver, deposit in other places, causing problems and organ dysfunction. So we have to reverse the iron toxicity with a D-iron agent, right? So D-ferroxamine or D-ferroxamine, what does it say? D-ferroprone, right? So D-ferroxamine is a more common one. All right, so how do you prevent all this? will prevent an infection in the first place, right? So we know they're functionally asplenic. Their spleen doesn't work great. So usually your spleen will tag bacteria that come through. So it's like going by really super fast, right? That little bacteria is going through, and it kind of tags it, right, as it's run through, kind of like a marathon runner. As that little salmonella goes through, it kind of tags it, and then that little marathon runner will make it to its destination, and the white blood cell sees that it was tagged, and it will then eat it, and then that bacteria, that will again get destroyed, right? So Haemophilus is something to that effect, is one of those bugs that we can prevent against. We mentioned Salmonella is not something we can, but Haemophilus is one. Meningococci, Neisseria is something we can vaccinate against. Pneumococcal for pneumonia and for pneumonia. We can then vaccinate for these things. So we usually have to get a triple vax. So you have 3 vaccinations: HIB, meningococcal, and pneumovax. Those are the 3 vaccinations we can give. And also we want to make sure they're getting their vaccinations yearly. The COVID vaccine, their flu vaccine, zoster, Hep B, all the things they can possibly get, they should be getting. All right, that way they are avoiding infection. Because what can infect them are things that would normally be tagged by the spleen, and that's called opsonized or optioned, I think of. So the spleen options or opsonizes these different bacteria, and those bacteria can cause a widespread infection, like Salmonella, for instance. Salmonella can then cause a osteomyelitis, and we have Pseudomonas. Pseudomonas cause a really nasty pneumonia, right? And that's not good. So these are the bacteria here. You come with a better mnemonic. I don't know, penis kiss is the best I could come up with. All right, and you can vaccinate against these 3 right here. Okay, those are the 3 that you can vaccinate against. But Pseudomonas, we got E. coli. It'll sneak on by if you don't have a spleen. So the spleen is there to tag it. Okay. So TB testing, because there's a risk for TB. Also surveillance to make sure they have wounds that are healing. Just because you're diabetic patients, osteomyelitis can be very, very deadly. We want to make sure they are avoiding any kind of infection and preventing as best we can.